So, Dr. Thase, I have a question here from our mutual colleague, Dr. John O'Riordan, and he says that, he thinks that these analyses are far removed from what actually happens in a psychiatrist's office, because you can use different agents over time. And so we may say that antidepressants work 55% of the time, but what about like after a series of trials? Is it not likely that we will get like an 80% response or something like that?
Well, yes, of course, and we know from epidemiologic studies that suicide is related to untreated depression, and that chronicity develops when people don't receive treatment, and so the cumulative benefits of effective treatment, whether the effective treatment's psychotherapeutic or with antidepressant medication, really do show themselves over time. You can be the best runner in the 100-yard dash, but you may not finish a marathon, and ultimately it's finding a medicine that helps in the short run, that's well tolerated and helps the person recover and sustain their benefits.
And Dr. O'Riordan also has a question that he thinks that it's very important to note that antidepressants are 2 to 3 times more effective than placebo in maintaining response. And so this is not a modest effect, and it's actually, he thinks that it's much more important even than the margin of advantage in short 8-week trials.
Well, that's true. If you see if you see an efficacy advantage of 10, 15, 20% in the short-term trials, the relapse prevention effects are basically double that. And so drug protecting people 80, 85% of the time, whereas 50% are relapsing on placebo. Now the anti-psychiatrists and Scientologists and such say this is because the drugs have become habit-forming and withdrawing them is dangerous. But people don't crave antidepressants, and they don't develop therapeutic tolerance to them. So what we're really seeing is that for a group with a defined benefit, people who have really responded to the medicine, the advantage of staying on an effective medicine is double that of whether the medicine would have helped you in the first place.
Right. But this 85%, just to clarify, what I hear you saying is that this 85% benefit in prophylaxis is for people who responded in the acute phase, not for unselected
patients.
Yes,
it's what's called an enriched sample. You only want to do a relapse prevention study in people who benefited from the treatment in the short run. That's for whom relapse prevention is important. But that sample has been selected. It is enriched for being benefited by that treatment, and that's why the effect of staying on it is larger.
So from this paper, the Cipriani et al. Paper, people are excited and they declare victory. Antidepressants have been shown to work. But what is the real answer? I mean, you're one of the leading experts on antidepressants in the entire world. What is the real answer to this question? Do antidepressants work?
Well, they work for some patients, and I think the most important question is most important comment is that treatment works. And treatment can be psychotherapy, it can be pharmacotherapy, it can be the two together. And pharmacotherapy is not just antidepressants, it's antidepressants, mood stabilizers, newer generation antipsychotics, and even on occasion benzodiazepines, as well as other kind of life-enhancing strategies like light aerobic exercise, or regular aerobic exercise, perhaps even losing weight, and some dietary interventions might make a difference. Between, say, 1985 and 2005, the use of antidepressants in the United States more than doubled, and the use of psychotherapy diminished by almost the same proportion. And we did not have such good evidence that antidepressants were better than psychotherapy to cause that kind of reversal. This was a cost-containing, kind of socially mediated change. And this is one of the reasons why people are sort of mad at and sort of resent antidepressants, because they're not all that they were cracked up to be. That doesn't mean that they don't work, they don't help. And when you add an effective antidepressant to a good psychotherapy, you do increase the chances of benefit. But the opposite is true also when you add a good focused psychotherapy to pharmacotherapy. So the all antidepressants all the time for every depressed patient
That's an exaggeration.
Is an exaggeration. A subset of those with least severe, less impairing illnesses do just fine with a good focused psychotherapy and lifestyle advice and management. And another proportion of patients, those with mixed features, those who have treatment emergent affective shifts, those who've had hypomanias and manias, and those who have psychotic features may need to take other medicines in addition or instead of antidepressants to benefit.
But I would say, I think that you and I are both concerned that in 2018, if a patient went to a psychiatrist and said that they have been feeling very depressed and so on, it's almost 100% chance that they would be prescribed an antidepressant. Do you think that's true?
Oh, I'm sure that's true. And I think even if that patient went to a family doctor, that he or she would probably have at least a 50 or 60% chance of being prescribed or sent to someone else with the hope that they would prescribe. And now if you did a real careful review of those particular patients, some proportion would have done just fine with focused psychotherapy, and some other proportion won't respond to antidepressants but will require some other treatment.
So one of the many terrific things, Dr. Thase, about your expertise is that you have an extensive expertise in cognitive therapy in addition to psychopharmacology, and you have authored several books, you have done NIMH-funded research on cognitive therapy. So as a colleague, if I ask for advice, like tell me which patients who come to me with depressive symptoms, should I not prescribe antidepressants initially? Other than less severity, are there any other advice that you would have for me?
Well, I think if you have a life event that is kind of the fulcrum, if you will, of how the depression developed, that working on what the meaning of that life event and how it's affected your life and upset your world, whether you're working on it interpersonally, psychodynamically, or cognitive behaviorally, that's a depression that may preferentially respond to psychotherapy, provided the person is not so overwhelmingly severe that they can't get out of bed or that they're not able to go to work. I think patient preference is a real important thing, and even when you're more severely depressed, if you have a strong preference to make a psychotherapy work, and you've got the time and effort and prefrontal cortical capacity to make it work, that you can do psychotherapy instead of pharmacotherapy under those circumstances. I don't think psychotherapy can treat psychotic depression. I don't think psychotherapy can cure bipolar disorder, although I think you can treat episodes of bipolar depression psychotherapeutically the same way you can episodes of recurrent unipolar depression.
Which is pretty amazing, given that bipolar disorder is well known to be a genetic biological condition,
well,
less heterogeneous than major depression.
Yes. Descartes was so wrong about this thing that our minds and our bodies are really so. Our brain and our mind are just two ways of looking at the same thing.
So if of the patients that come to you with major depressive disorder, can you make like a rough guess, like what percentage you don't prescribe an antidepressant to initially?
The only place here at Penn that I get to see de novo patients who are making their first decision is at the Cohen Veterans Family Center.
Yeah.
And here I'm seeing a preponderance of Gulf War and Operation Desert Storm vets and their family making their first decision about whether to take a medication or not.
Yeah.
And evidence-based psychotherapy is available for every patient as an alternative if they don't want to take medicine. And I think I'm prescribing at the first visit about half the time for those patients, and about half of the remainder I will prescribe down the road if they've not made psychotherapy work for them. So yes, that means I ultimately am prescribing for about 3/4 of the patients I started
But
out
it's
with.
terrific to know, that is really terrific to know, and I just want to emphasize so that the listeners can understand this. I mean, as a leading psychopharmacology expert, you don't prescribe antidepressants to every person with depression whom you see. You allow them to have psychotherapy first, and then you reassess, and maybe 25% of them, you're saying, just as a rough idea, might not need an antidepressant.
And look, even when I have the clinical sense that I think this patient would benefit from an antidepressant, as long as he or she's not delusional, not incapacitated, and not imminently suicidal, I'm A-OK with taking a kind of watchful waiting approach. If the patient's so ambivalent about the decision to take a medicine that I might have to talk them into that process, I would much rather, again, in a world in which psychotherapy is available and I have the opportunity to see the patient back in 2 weeks, 3 weeks, 4 weeks, let's get together, look at your progress, and make a decision based on whether you're getting better or not as far as prescribing under those circumstances.
So in roughly how many weeks, so one problem, or not problem, but one characteristic of psychotherapy is that it requires a little bit longer time to show clinical benefit. So after how many weeks would you think, I've given this psychotherapy enough of a try, let's try medicine?
If you've not gotten a 20% reduction in your symptom profile after 4 weeks of psychotherapy, you're probably not going to be a responder in the short run, in the 10, 12, 16-week kind of period. It's sort of like if you've not seen 20% benefit in the first 2 weeks on a new medicine, it's likely not to work. Psychotherapy takes about twice as long as pharmacotherapy to show its stuff. But that's interesting. And again, if someone's not gotten to a response level of relief of depressive symptoms by, say, 4 weeks, by, say, about 8 weeks, then I'll be thinking about adding pharmacotherapy to continued psychotherapy.
So it doesn't require delaying treatment with antidepressant for months. Even like if you wait for 1 month for psychotherapy in the appropriate patient, there is some beneficial data, and certainly by 2 months.
And the teaching points I like to make with my new patients is that depression affects your life in all sorts of ways, and these effects are growing and they're like rippling like the stone in the pond, and that if you don't feel like going out, you're going to not only have less fun, but you will be kind of distancing, perhaps even turning off your friends. Maybe new opportunities will not come your way. If you're not networking, you're not likely to get more professional opportunities. And if you continue to work at 50% of your normal work capacity, no matter how kindly your boss is, he or she's going to take notice, and you're going to suffer for this in the long run. Similarly, having a depressed spouse is depressing.
Yeah.
There's evidence that one risk factor for depression within family, both for partners and children, is a depressed mom or a depressed dad. And so you can see negative effects rippling into the family. And of course, any other health condition you have is going to be made worse by ongoing depression. So we don't want to let these things go on for too long.
Yeah. Right.
But again, personal choice needs to be respected.
What about the argument? Some people say, well, this is a moot point. Everybody should receive an antidepressant and psychotherapy, which doesn't seem realistic in terms of logistics and cost. But so, what is your feeling about this? Like, should we not start everybody with?
I don't have a precise estimate of the number of people that can't use psychotherapy, but I do know that a significant minority of human beings in North America at this time have no use for psychotherapy and no interest in engaging it. And whether it's 1 in 8 or 1 in 4, it's a considerable minority of people just aren't interested. So
because they're not psychologically minded.
They're not psychologically minded. They have issues about intimacy and confidence and trust and so forth. So I mean, maybe such people could get going in self-help groups or in exercise programs and so forth. There could be non-pharmacologic alternatives. It's not all medicine all the time for those folks. But there are some people that I think it's actually sort of a cruel and unusual punishment. I'm teasing. But a waste of a precious resource to kind of make them go into therapy. This is why I don't really like institutional policies that require that before you can see the psychiatrist, you must see the psychotherapist. Right. I think there are some number of other people who temporarily can't make use of psychotherapy, and these would be people who are more overwhelmingly ill and those who are currently deluded and so forth.
So if the patient was willing and seemed like a person who could benefit from psychotherapy, what about like a possible disadvantage of starting both together might be that you don't know what worked and what should be continued long term?
That is a potential disadvantage. I think that I know if the person feels better in the first 2 weeks, it's probably the pharmacotherapy part, because that's the benefit is earlier.
Yeah.
I think if there's very little movement in pharmacotherapy, and then between weeks 8 and 12, suddenly the person starts doing a lot better. I think you've got evidence that that's the therapy
Right.
kicking in, but sometimes you don't know. And you know, our clinical care is informed by experiments, but isn't an experiment in and of itself.
Judgment will be needed, yeah. Great.